Since the paradigm change of 2005, when we received the first-in-class approvals of VEGF TKIs, sorafenib and sunitinib, we have been plagued with ultimate VEGF refractoriness. Once a VEGF inhibitor is started in a patient, it appears to be only a matter of time before resistance will develop. We also have been plagued by the recognition that there has always been a population of patients that appear to be primarily refractory to no matter what we do or what we give them. That in traditional VEGF inhibitors such as sunitinib would be around 20% of the patients. So we have two types of resistance that we focus on. We focus on the group of primary refractory, which would be that patient that is started on a VEGF inhibitor and it seems to have no benefit whatsoever. The first imaging studies show progression. And then the second group, more common group, which is those patients that ultimately develop recurrence. This latter group is actually a group which has many different flavors. There are patients that have initial control and then rapid development of resistance. There are patients that have resistance that develops in multiple new sites of disease, those that have resistance indicated by just slow growth of existing disease. So you can see there are many different categories that ultimately suggest different biologies at play. We have spent many years trying to understand this concept of angiogenic resistance, and a lot of research has been done to escape mechanisms. FGF, c-Met, AXL are just three examples of factors or proteins that may be upregulated at the time of angiogenic escape. There's also belief that these same factors may be upregulated in those that have de novo primary resistance. Having multi-targeted agents that target these factors either at initial presentation when you start therapy in the frontline setting or at the time of resistance when these agents are used as a second line or refractory therapy is important. That's the theory. There's basic science that supports that. The proof is in the clinical trials. And we have seen now several clinical trials done. For reference, the lenvatinib everolimus combination trial versus everolimus, and then the cabozantinib versus everolimus trial, showing indeed that this theory translates into absolute efficacy in clinical study.
Currently, there are still not very clear biomarkers that have been able to guide us in terms of how resistance develops or predictive biomarkers that predict resistance. However, what we do know about the TKIs is they are really multi-kinase inhibitors and targeting multiple different kinases. In some ways, even though we're using one drug, if you think about it from a target perspective, you're actually using combination therapy of sorts. And when we think about combination therapy and hitting multiple different kinase targets, this becomes critical in order to achieve better responses. Among some of the pathways that have also been critical as anti-angiogenesis include both the c-Met pathway and the FGF pathway, which later developed TKIs tend to address.